Good evening. This is Dr. Lisa Homa. Thanks so much for coming tonight. I'm going to complete my portion of the lecture after Professor Rapé, and we're going to talk about cultural competency and how to perform a culturally sensitive holistic health assessment. The objectives of this lecture are to perform a culturally sensitive holistic assessment on vulnerable individuals and families. Now we're going to focus on creating a comfortable environment that is culturally sensitive and holistic for our patients. 7 comfort tips from the literature to create a space worthy for holistic assessment. So the first stage, setting the stage, is getting to know your patients. So what is your ability to comfort your patients? If you want to build stronger bonds with your patients, provide high quality healthcare, there's 5 steps to making your patients more comfortable and relaxed. And the first one is getting to know your patients. Think about all the struggles that we have trying to get to an appointment sometimes, especially if you're not the patient. Let's say it's your child or it's your loved one, a spouse or a parent. Think about what a struggle it is to get another person to an appointment. Just coming to a nice, welcoming, warm environment would just kind of put everything at ease. The key to creating the inviting environment. We're kind of limited depending on the setting. If you've been into a doctor's office lately, sometimes just based on the setting or whatever they transformed into a doctor's office, sometimes it's not possible to get natural light. There may not even be a window in the exam room. There may not be nice paintings or anything like that in the space that you are in, but do the best you can. So here's a couple of Florence Nightingale's, and we're following her environmental theory on what she said can create a more comfortable environment for our patients. So we want to establish open communication and that the patient is comfortable asking questions. We want to allow in the exam space as much natural light as possible, if possible. Advocate to create that the exam rooms are welcoming and inviting. Ensure that the space is clean and organized before the patient enters the room. Have you ever been to an appointment and the paper is still all crumpled up from the previous patient, so nobody has cleaned it or wiped it down? That's not good. It's not inviting. You want to make sure that be sure you call the patient by the correct patient name. And 2, because of cultural sensitivity, you want to make sure that you address the patient in the most respectful manner you can. In some cultures, it is disrespectful to call them by the first name. So you want to be sure that you call them by the most formal way of addressing them at first, and then asking permission to use their first name or other nicknames or whatever it is. Be attentive and take interest in the patient's story, and be learning compassionate listening. Up in the coming months in our courses, I have guest speakers coming in who will be talking to us about how to do it. They believe they've been in working with the COVID teams, talking to them about debriefing, and they think everyone has a story to share. So I'm going to be so excited to have them come in and to teach us how to be compassionate listeners. You want to consider, what if, just offering the patient a glass of water, if they look overwhelmed, tired, or flustered, anything, ask them if there's something else you could do for them. Listen to what the patient says, truly listen and be empathetic. And then I thought it was important to mention the differences between sympathy, empathy, and compassion. So what we're called to do as a nurse is our goal is to relieve another's suffering, right? We're called to be compassionate. But I hear sympathy and empathy used synonymously, and I thought it was interesting because I feel like people call them the wrong thing all the time and what they are. I feel like we need to be sympathetic in many instances. So you want to understand someone else's hardship and express that you feel, regret for the things they're going through. Empathy, on the other hand, is you share emotions and experiences, and the goal is to understand and relate to another's feelings and experiences. You want to be able to establish sufficient boundaries with that. The health assessment book tells us that we need to be empathetic, but I feel like those terms are used incorrectly a lot of the time, and it's very difficult to be empathetic and say, well, I understand what it's like to be in your shoes, if you don't understand what it's like to be in their shoes. Okay, the components of a comfortable assessment are to adjust the temperatures. Ask them, how is the temperature? Are you cold? Are you hot? If they're cold, you can offer blankets. You can offer to turn down the temperature in the room if possible. And then what can you do to cool a patient in an office? Maybe provide them with a cold compress, an ice pack, lower the temperature if you're able to, and provide them with a cold drink of water. And also verify what the patient's temperature is. Maybe the person has a fever. You don't even know. I've had many instances where we go round and round about worrying about the temperature, and then here come to find that the patient has a fever. And then we want to educate our patients and their families. I know you're going to say, we already do this, and nurses are generally very good teachers. But what they don't do, and I can tell you from my experience at Penn, is nurses are bad documenters of education. It's the number one area where nurses fail to document in the electronic health record is education. But do you really do this? Yes, but do you really document it? Make sure the patient is informed on their health status. And if they don't understand what's happening to them, sometimes patients are just incapable of their understanding or comprehending their health status. But it's your job that if they don't understand, to provide re-education by connecting that person to a provider or someone who can help them, hopefully, to understand what's really happening. And then who cares about the caregivers? In a lot of health systems, they're starting to implement caregiver assessments. They say in nursing, everything's about patient-centered care. I do believe it sounds more like we need patient and family-centered care. The caregivers are often forgotten. They're not even thought about and considered. The caregiver's health starts to fail. Meanwhile, we could have done something. We could have intervened somewhere along the way to find out how they were coping with their life as a caregiver. And then follow up with patients. As a change agent, I'm going to use the words of great Maya Angelou, who said, once we know better, we do better. Let's just give an example. Once you're a change agent, you can implement all these processes and make life better. Like, let me give you an example of something that I worked on, a project I worked on at Penn. Our nurses didn't do follow-up calls after intervention procedures, and we thought, well, we should be doing that. That's just a nice thing. Imagine if the nurse called you from the hospital a day or two after you were discharged. Wouldn't that be a nice thing? And wouldn't you appreciate that so much? But are you thinking, we don't do that? So once you're a change agent, you want to start thinking about all of these processes and how that would make you feel. You can work on creating a process where nurses make follow-up calls. You can create educational materials of frequently used observed discharge needs. What if your discharge paperwork is terrible and patients are always calling, asking questions? You can do something to fix these things. You can choose to be more proactive in your approach with patients. And then create caregiver assessments. That's another thing. You can have a little checkbox along your patient assessment in the office when they come in for an office follow-up and ask, did you check in with the caregiver to see if expressed any needs for the patient or themselves? And then spend time with your patients. This is extremely difficult since follow-up visits are tied to times, right? So we're always in a hurry. It could be my bias coming through. But when I'm working in ICU, I spend time talking to my patients and washing their hair and doing all these extra things because I love spending time with patients. But when I call them young chippies. When I'm with the young chippies, I see them on their phone continuously instead of texting while you are at work. Spend time talking with your patients and providing extra care to them. I am famous, and you can ask any of my students about this in clinical, I'm famous for the term flybys. Have you done flybys? And all that is yes, you may be really busy. Let's say you have 2 patients in ICU and one of them is crashing all day. You may not be able to get in to see your second patient that much, but by doing a flyby, as you're running by, you may be able to stop by and say, hey, how are things going? Do you need pain medicine? What is it that I can do for you? And even though I'm really busy in the next room, I'm going to send somebody in to do that for you because that's what you deserve. Flybys are important. 20 seconds to tell a patient and their family you care about them. And if you can't meet their needs, get someone to meet the need for you. And then be positive. Patients want to feel that someone is helping them or watching over them. If they're in pain or discomfort, they can't just be sitting there suffering by themselves. That's our job. Remember, comfort theory, the 3 central attributes of comfort theory are relief, ease, and transcendence. The big fancy schmancy word transcendence just simply means taking a patient from an area, like let's say, for example, they're in pain, and we want to transcend them to an alternate universe, out of pain, comfortable, in a much better place than where they previously were. That's the goal of our care. It doesn't matter how bad the diagnosis is. It's not our job to be judgmental about anything. It's our job to create a safe space and be as positive as possible. Leave all the miracles to faith for you. You just need to be a positive pillar of strength for your patient. Your attitude could help ease a patient's discomfort. You have no idea. There could be people in their family that don't want them to take chemo again. There's just so many dynamics that happen in families. That's not our job. Our job is to be objective, present with the facts, and be as positive as you could be without presenting false hope. Remember, if culturally appropriate, smile, make eye contact, and watch your tone. Be comforting, calming, and kind. Remember, smiling and eye contact sometimes are offensive or disrespectful in other cultures, so you want to follow the cultural lines of sensitivity with your patient and family. Recognize and reduce anxiety. We probably know this as nursing students very well, the difference between stress and anxiety, but just remember, there are these physical symptoms that come along with all of these things, and really stress. Look at how stress can cause all these additional symptoms, even over and above anxiety. So just think about these patients, when their loved ones are sick, they are stressed out. I would not be surprised if they didn't have a combination of 3 or 4 of them, if not more, of the symptoms that you see up on the slide. Let's talk about the 4 C's of culture. First C is call. What do you call your problem? This is to remind the provider to ask, what do you think is wrong? Careful not to fall into the trap of focusing only on what the patient thinks is the problem and ignoring other possibilities. Sometimes patients share their story with the provider and they go down this rabbit hole where they're focusing on 100% of what that patient said. And yes, you want them to hear you, but they're also the medical clinician that needs to also diagnose what that cause is. The second C is cause. What do you think caused your problem? This gets at the patient's belief system regarding the source of the problem. What's interesting about this is that here in the United States, our Western medicine practices do not think about other cultures. The Eastern part of the world believe that illness can result as a consequence or a penalty to a sin they've committed or things of that nature. And the third C, cope. How do you cope with your condition? This is to remind the provider to ask, what have you done to try to make it better? So what are the alleviating factors? Some cultures, people do not want to go to the doctor no matter what. They will go above and beyond to make sure that they've tried every holistic thing in their mind before they even think about going to a doctor. And the fourth C is concerns. What concerns do you have regarding the condition? This question allows the provider to ask how serious the patient thinks the problem is and what complications does the patient fear as a result. And the next is communication considerations in culturally sensitive care. Avoid the use of idioms. Just saying, to be honest with you, those things are really confusing, especially if you're a second language learner. You don't want to use idioms or common phrases because they can be culturally misinterpreted. The same language, different meaning. In the Philippines, a rice cake means, if I used a certain word, it means something completely different to an Asian culture. So you want to be careful about using those. Again, very similar type of thing, same word, but a different language could mean something disrespectful in another language, so be very careful. And when yes may mean no, so for example, someone who is hearing impaired, there are certain, even in sign language, not every single thing can be interpreted or translated all the way through, so you want to be sure. Also, positive and negative test results. Here's an example with the hearing impaired. Not everything translates 100%. A patient asked if they were told the test result was positive and they thought that was a good thing. And here the patient found out she had HIV. So it was not a positive thing, but they took it initially wrong because of the translation. And then culturally sensitive care with the LGBTQ population. So here are some key terms. Ally is exactly what we think it is. It's someone who's supportive of the LGBTQ population. Asexual is lack of a sexual attraction or desire for other people. Biphobia is the fear or hatred of people who are sexually attracted to people who love more than one gender. Cisgender is a term used to describe a person whose gender identity aligns with those typically associated with the sex assigned to them at birth. So if you're born a female, you will follow that assigned gender. Gender binary is a system in which gender is constructed into 2 strict categories, only male or female. There's nothing in between. There's nothing fluid. It is what it is. Gender dysphoria is a clinically significant distress caused when a person's assigned birth gender is not the same as the one they identify with. Gender expansive is a person with a wider, more flexible range of gender identity and/or expression than typically associated with the binary gender system. Gender fluid is a person who does not identify with a single fixed gender or has a fluid or unfixed gender identity. Gender identity is one's innermost concept of self as male, female, or a blend of both, or neither. How individuals perceive themselves and what they call themselves. One's gender identity can be the same or different from their sex assigned at birth. Gender nonconforming is a broad term referring to people who do not behave in the way that conforms to the traditional expectations of the gender and whose gender expression does not fit nearly into a category. While many also identify as transgender, not all gender nonconforming people do. Genderqueer. People typically reject notions of static categories of gender and embrace a fluidity of gender identity, and often, though not always, sexual orientation. People who identify as genderqueer may see themselves as both male and female, neither male or female, or falling completely outside of those categories. Intersex are people born with a variety of differences in their sex traits and reproductive anatomy. There's a wide variety of difference among intersex variations, including genitalia, chromosomes, gonads, and sex organs. Lesbian is a woman who's emotionally, romantically, and sexually attracted to other women. Non-binary, an adjective describing a person who does not identify exclusively as a man or a woman. They identify as being either both a man and a woman, somewhere in between, or falling completely outside of these categories. Pansexual describes someone who has the potential for emotional, romantic, or sexual attraction to people of any gender, though not necessarily simultaneously in the same way or same degree, sometimes used interchangeably with bisexual. Queer, term used to express a spectrum of identities and orientations that counter to the mainstream. Queer is often used as a catch-all to include many people, including those who do not identify as exclusively straight or folks who do not have non-binary or gender-expansive identities. This term was previously used as a slur, but has been reclaimed by many parts of the LGBTQ movement. Questioning, term used to describe people who are in the process of exploring their sexual orientation or gender identity. Transitioning, a series of processes that some transgender people may undergo in order to live more fully as their true gender. This typically includes social transition, changing names, pronouns, medical transition, and may include hormone therapy and gender-affirming surgeries and legal transition. Holistic health assessment. So I have the links for these videos on the course, and they are fantastic. They go into how we have these different scenarios and how we can appropriately and sensitively talk to our LGBTQ patients, assess their health history so that we don't miss any gaps that are typically missed in their care. And then case study, Mr. C is a surgical ward recovering from a prostatectomy. His primary nurse is trying to arrange a good oral intake and takes care of explaining why this is necessary. However, Mr. C, who is of Chinese origin, consistently refuses to take cold drinks, which he is offered. Do you have any insights into Mr. C and why he's not taking the cold fluids? Burst your bubble, but here is the answer. The drinking of cold fluid does not fit with Mr. C's idea of humoral system and beliefs about health and healing. Surgery is considered a hot condition, and drinking of cold water is considered unhealthy and should be avoided at this time. In this situation, a warm tea at the bedside would be more appropriate. Thanks so much for listening. I'm so glad that you made it here tonight. It's great talking to you. Have a great night.